Welcome to the endometriosis session. This is the 4B sessions of the 2021 Central Vietnam Scientific Congress of Gynecology and Obstetrics. I would like to introduce the session chairman, Professor Nguyễn Viết Tiến, President of the Vietnam Association of Gynecology and Obstetrics, Professor Nguyễn Vũ Quốc Huy, Vice President of Vietnam Association of Gynecology and Obstetrics, Head of the University of Medicine and Pharmacy, Professor Lê Minh Tâm, Head of the Center of Reproductive and Endocrinology and Infertility, Vice Head of the Faculty of Obstetrics and Gynecology, Huế University of Medicine and Pharmacy. Now the chairman will moderate the session.
Thank you for your kind invitation to this outstanding meeting. I have three parts of my talk. One is the current status of adolescent endometriosis, and the second part I will talk about our recent findings and our ongoing study on the development of adolescent endometriosis. And finally, I want to show you some recent problems that are associated with adolescent endometriosis. I have no COI related to my lecture. Current status of adolescent endometriosis. So this is a study from Japan, annual report of Japan. Endometriosis treatment rates per 100,000 women population. As you can see here that in 1997 there were 58 teenagers per 100,000 women population, and in 2014 this prevalence goes down to almost half, 29 per 100,000 women population. So this may be due to the reason that adolescent endometriosis cases itself is decreased, or they don't want to visit OB/GYN doctors because they just want to self-control, or they want to manage their pain by the non-prescribed medicine. Or it may be possible that in 1997, all adolescent endometriosis cases were diagnosed based on symptoms, and in 2014, these cases were diagnosed based on the image. Sorry. Let me talk about some other study. According to the Belgium study, among more than 1,000 study population, the frequency of in the prevalence of adolescent endometriosis was 0.9%. So we performed a retrospective study in order to evaluate endometriosis in adolescents in collaboration with the single institution, and we found that during the period between 2009 and 2015, among 3,455 laparoscopic surgery cases, about endometriosis was diagnosed in 37% of cases, and among 1,270 cases, the adolescent endometriosis cases was only 18, 1.4%. And among these 18 cases with adolescent endometriosis, the 11 cases belong to early stage endometriosis, stage 1, 2, and the remaining 7 cases belong to advanced stage, that means revised ASRM stage 3, 4. And let's take a look into the morphological appearance of the adolescent endometriosis. As we can see here that in both stage 1, 2 and stage 3, 4, the most of the cases with adolescent endometriosis cases, they had the hemorrhagic peritoneal lesions. As you can see here that most of the cases had the coexistent red lesions. I'm sorry. So if you can take a look at ovarian endometrioma as investigated by ovarioscopy, it's a kind of contact laparoscopy. As we can see here that in adolescent women, the ovarian endometrioma is highly vascularized mucosa, and they had white or pigmented cortex. And in contrast, in adult women, the ovarian endometrioma tissue contains less vascular mucosa with dark pigmented fibrotic tissue in the cortex. These findings indicate that progressive the phenotype of ovarian endometrioma in adolescents. Now I want to talk with the current development and to propose some new concept on the origin of the adolescent endometriosis. As you know that Dr. Sampson's menstrual reflux theory and also Dr. Robert Meyer's the coelomic metaplasia theory are two very famous hypotheses on the pathogenesis of endometriosis. I think we can also link these two hypotheses with the development of the adolescent endometriosis. I want to propose a new hypothesis, that is the neonatal uterine bleeding could be associated with early onset endometriosis affecting adolescent girls. According to the Belgium study, they reported that neonatal uterine bleeding could be the origin of early onset endometriosis because they hypothesized that neonatal uterine blood contains stem cells, and these stem cells in the neonatal uterine blood, if they goes back to the pelvis, they can differentiate into the endometriotic-like tissue, and this could be one of the explanation of early onset endometriosis. And according to the Belgian study, they found that neonatal uterine bleeding affects only 3 to 5% of newborn girls, and it occurs often 3 to 7 days after birth. And even if there is no overt NUB, occult NUB may occur due to the blocking of the fetal long cervical canal by thick mucus plug. And they also reported that some factors that were associated with the risk of NUB, such as post-maturity and preeclampsia, and some factors such as prematurity was associated with decreased risk of NUB. I'm sorry. So we tried to reconfirm the prevalence of NUB by undertaking a retrospective search of obstetrical medical records for the last 5 years, 2013 to 2017, and we found that neonatal uterine blood among 807 newborn female babies, neonatal uterine bleeding occurs in the 25 cases with a prevalence rate of 3.1%. And our prevalence rate coincided with the previously the published reports, as you can see here in this slide. We found that neonatal uterine blood occurs 4 to 5 days after birth, and this neonatal uterine bleeding continued only 1 day in most cases. And what we did next, we searched all the maternal characteristics and also the neonatal characteristics, and we performed the multivariate logistic regression analysis with adjusting different confounding factors. And we found that the gestational age, 39 weeks or longer than 39 weeks, was significantly associated with the risk of NUB. And we also found that younger age of the mother was also significantly associated with the occurrence of NUB. And in addition to that, we found that some comorbid disease of the mother was associated with the risk of NUB. So now next question is neonatal uterine bleeding in newborn female babies, when these babies grows up to the adult women or the adolescent women, do they complain of any symptoms related to endometriosis? In order to address this question, we went back 20 years before to search the occurrence of neonatal uterine bleeding from 1996 to 2000, and we found that the prevalence rate among 105 NUB cases, the prevalence rate of neonatal uterine bleeding was 9.3%. This is about 3.3 times higher than the current data. And in this slide, we just compare any difference in the gestational age or the maternal age between these two time periods of neonatal uterine bleeding. We found that gestational age at birth was significantly longer and maternal age was significantly younger in 1996 to 2000 than in 2013 to 2017. So we performed an online questionnaire survey. We call each and every young ladies. So my PhD students, they worked hard on this study, and they call each of them, and after that, and telephone contact was possible with NAB cases 105 and NAB minus cases 771, and finally we could receive response of our questionnaire survey from 31 NUB cases and 52 NUB minus cases who are now adult or adolescent. So this is the demographic profiles of young women who were born with and without NUB. As we can see here, that NUB positive cases was significantly the younger comparing to the NUB negative cases, and the gestational age at birth was significantly longer in NUB positive cases than in NUB negative cases. So here is the response to the questionnaire survey. We had many questionnaires, but I want to select some questions, especially some questionnaires response survey responses or some symptoms that are related to endometriosis, such as: do you feel constant cyclic or acyclic pain? Do you feel the severe endometriosis as measured by VASA score? Or do you have any cyclic or acyclic severe pain? Is your cyclic or acyclic pain disturb daily life activity? Do you need to absent from school or work during cyclic pain? Do you need to take any painkiller or hormonal therapy for your cyclic pain? Or was your medication useful to relieve your pain? We should know that all these the questionnaires or symptoms were related to endometriosis. And we found that there was no significant difference in these symptoms between NAOB positive cases and NAOB negative cases. That means that NAOB positive cases equally suffer from symptoms related to endometriosis comparing to the NAOB negative cases. So this is the last part of my talks about the problems of endometriosis. Endometriosis is a big problem for the women's health. So now the question is, how big is the problem? There are many problems. One problem is if these women suffer from, or the adolescent women suffer from endometriosis, they suffer from a degree of moderate to severe pain, and this pain may cause a decrease in their quality of life. And another problem is endometriosis causes inflammatory reaction in the endometrium or in the pelvis, and this inflammatory reaction may cause a state of subfertility or infertility. And another problem is a proportion of ovarian endometrioma, they may undergo a malignant transformation. As you can see here, that malignancy rate from the chocolate cyst is 0.72%. So this is the Japanese study, our Japanese study. Another problem is not mentioned here, that is the recurrence. Even we do the recent hormonal treatment, or even we do the surgical management by an expert surgeon, there is obvious recurrence is there. We cannot protect recurrence. So this is one of the another problem. So another problem, big problem, still remains that these teenage girls, there is a very big diagnostic delay. They don't want to, these teenage girls, they don't want to visit the OB/GYN doctors. As you can see here, that time interval between the onset of symptom and the final diagnosis in these groups of adolescent girls is 10 to 12 years. And we can also see here that even in women in their 20th years or 30th years, this diagnostic delay between the onset of symptom and final diagnosis is 3 to 5 years. So this now the question is how we should resolve this problem. So we should motivate all these young women to visit gynecologist, to take an examination for early diagnosis and management of endometriosis. So with this purpose, recently we established a multinational and a multi-center study, endometriosis awareness promotion project. So this study, the study population is the medical students and the nursing students. So based on the questionnaire survey, our purpose is to identify the high risk group. As I already mentioned, that some problems and symptoms, all these symptoms are related to the high risk group, and our purpose is to identify the high risk group and who are supposed to develop endometriosis, and we want to motivate them to visit a gynecologist to take an exam for early detection and management of endometriosis in these young women. Then you can see here that many Asian countries and many universities in Japan are kindly participating in this study. We almost completed this study, but still some of these universities are still performing their questionnaire survey, and we're going to soon summarize this study on this EAPP project. So I want to thank all members and active members of HOA University of Medicine and the pharmacy, particularly Professor Tam and all members of his group for their outstanding contribution to this project. So this is the take-home message of my talk. Number one, information on current status of adolescent endometriosis is limited. We need further study. Number two, we confirm that NUB indeed occurs with the prevalence of 3.1% that coincides with the previously published reports. The gestational age over 39 weeks and younger maternal age were significant risk factors for NUB. And our questionnaire survey indicated that comparing to cases without NUB, young women who were born with NUB equally suffer from symptoms related to endometriosis. Our ongoing study with neonatal uterine blood and neonatal endometrium collected from autopsy cases may clarify the link between neonatal uterine bleeding and early onset endometriosis, and this may be associated with the development of adolescent endometriosis.
Thank you very much for the presentation from Professor Khan. We would like to introduce and invite the next speakers, Professor Deborah Bush. Professor Deborah Bush is the board member director of World Endometriosis Society. She's also the consultant and co-founder of Endometriosis New Zealand and director of endometriosis and pelvic pain coaching and consulting. So please, Professor Deborah Bush.
Thank you so much for that very kind introduction, and good afternoon in Vietnam and good evening from New Zealand. I'll quickly move on to the next slide. I do have a disclosure. I will be referring to the ME, or Menstrual Health and Endometriosis Education Program in schools. I own the IP, but I have never received royalty or license fee. Today, I have a question for us, and that is looking at the global prevalence of dysmenorrhea between 45 and 95%, I'm going to ask you, will we find pathology in those with dysmenorrhea? Should we investigate further? And should we be concerned? And we'll have reminders of these questions throughout this presentation, and again, a summary at the end. Firstly, a quick look at some of the literature. This is a very nice study involving 21,500 young women, a systematic review and meta-analysis. And we can see the results from the study down this side of the screen. But today I really want to draw your attention to the key finding for me, which I think is relevant, and that is that dysmenorrhea affects 71% of our under 25s. This is indeed something we should be very concerned about. Furthermore, another study from Australia with 4,200 young women in the cohort between 13 and 25. Dysmenorrhea was high, irrespective of the country, and had a significant effect on schooling and also higher education. So we're going to have a quick look now at primary dysmenorrhea and secondary dysmenorrhea. Very quickly looking through, the onset is around about the same as is the onset of the pain. And then we're having a look at the symptoms. And once again, we can see that the symptoms are very similar in primary and secondary dysmenorrhea, except in secondary dysmenorrhea, we often see other gynecological symptoms such as dyspareunia developing. In primary, we don't generally find any abnormality on examination or tests, but we do with secondary dysmenorrhea, and there might be some nodularity or things showing up in a scan. I really want to draw your attention to this. Should we therefore dismiss primary dysmenorrhea and say that there is no pathology because we didn't find anything in our examination or our tests? Remembering that the effect is 45 to 95% of dysmenorrhea, will we find pathology? Should we investigate further? Should we be concerned? Again, we'll answer those at the end. What's more, we know that adolescent females with severe dysmenorrhea have disrupted development, disrupted education, missed job opportunities, and emotional, psychosocial, and physical health. But the thing that I want to draw your attention to now is the mental health that these young people often experience. They start getting worried about their schooling, planning their timetables and activities and exams even around their menstrual cycle, going out with friends, and this affects them greatly and something we're learning more about today. Globally, we know that school absence due to dysmenorrhea is between 20 and 31%. There was a very nice study in Canberra called the Menstrual Disorders in Teenagers study, which showed us that 25% of youngsters miss school often or always because of dysmenorrhea. And in our own study in New Zealand from the ME program, we found that 27% often or always miss school because of dysmenorrhea. So how do we address this? As Professor Khan showed us very nicely in his presentation just gone, what are we going to do? And we think that early recognition of symptoms and timely intervention could well be had with education, and that may be the best screening tool for us going forward. We're all aware of the symptoms, and I don't want to spend a lot of time on these, but I think that we should draw attention not just to pain with periods, but also look at the other presenting symptoms. So we are asking our young people further on from their pain, and please don't ignore the bloating and the constipation or the irritable bowel type symptoms that these youngsters often present with. In our message to school, we often say discomfort can be normal, distress is never normal with a period. And further, my colleague, Mr. Michael East, who I work very closely with, has put up a very nice slide for some diagnostic bell ringers for us. In other words, these are the things that we should be very alert to when we have our young people presenting. Menstrual distress is always abnormal. Mid-cycle distress, always abnormal. Pain with defecation, always abnormal, as is pain with micturition. Pain with sex, always abnormal. And pain predating menstrual flow and localized dysmenorrhea, please be suspicious. I want to introduce you to Janie, who is a young patient of mine I saw in August, September of this year. She's aged 18 years and she'll be 19 next year. She had a very normal childhood, so there's a little bit of information for you. She was outgoing, lots of friends, very good at school, a very supportive family. She was not ill during her childhood, but one of the factors that we should always remember is family history, and make sure you ask the question. Janie's mother had advanced stage 4 endometriosis with early hysterectomy and bilateral oophorectomy. So what happened to Janie when she got her period at 12 years old? You can see from this list she had severe dysmenorrhea right from the beginning, and with debilitating and fluctuating bowel habit, bloating, pain on defecation, cyclic headaches, fatigue, abdominal pain, lower back pain, and pain using tampons. Socially, she had some time off school. She was withdrawing from her sport and her dance and social activities. At age 13, she had multiple presentations to the emergency department at hospital and regular visits to her GP. She was prescribed combined oral contraceptive pills and non-steroidals. At 14, she was on regular tramadol and oxycodone, and she was becoming withdrawn and isolating herself. At 14, she had a laparoscopy, which was unremarkable and negative for endometriosis. But here's the thing, the symptoms continued unabated, but her mental health was causing great concern. My question is, what do you do next? Well, a reminder, the laparoscopy, remember, for endometriosis was negative. So what happened to her between the ages of 15 and 18? Well, the investigations continued. She had 2 colonoscopies, a gastroscopy, scans, bloods. All of them were unremarkable. She was reviewed by a gastroenterologist, endocrinologist, a clinical psychologist, a pelvic physiotherapist. She saw a dietitian, and she was following a FODMAP and gluten-free diet. Her symptoms worsened and intensified. The medical cocktail now included antidepressants. Remember, she's only 18 years old. She maintained her academic studies, but has withdrawn from all other social and sporting activities. Remember, the laparoscopy was negative for endometriosis. In August 2021, so just a few months ago, Janie's father contacted me. I referred her to a colleague with expertise in surgical treatment and management of endometriosis. In September 2021, just 2 months ago, she had another laparoscopy. Severe stage 3 endometriosis and adhesions were found, and on the surgical note, it wrote painstaking excision. Now remember, the laparoscopy when she was 14 was negative. And during this time here between 15 and 18, no gynecologist would do a repeat laparoscopy because they said she did not have endometriosis. Now, this is not a reflection on this general gynecologist. At this time, he saw what he saw and he didn't see endometriosis. I want to draw your attention to this because just because somebody has had a negative laparoscopy doesn't mean they may not have the disease. So I think we need to be open-minded, particularly in this very young age group. And let's not, stage 3 at 18 years old is quite an advanced stage. So what happens to Janie now? The advanced laparoscopy fully excised the disease. She had adhesions removed and a JDS placed. We're following a multidisciplinary approach. She's still seeing the dietitian. This is a letter that I received from her mother just a few weeks ago, and her mother said it's such a wonderful feeling to see her blossom once more, and was very, very thankful. Next steps for Janie. My advice is that she needs to take a breather, finish school, finish his last year of school and her studies, spend some time with her friends over the coming summer holidays in New Zealand, and we're going to follow a multidisciplinary approach for her if symptoms persist. But the family and Janie are very happy. So what do the guidelines say then about what we should do with young people? So I looked at the new New Zealand clinical pathway for the treatment and management of endometriosis. I reviewed the new RANSCOG guideline released from Melbourne, Australia, just a few months ago. I looked at the NICE guideline, the ESHRA guideline, which of course is up for renewal, and the consensus on the current management of endometriosis by the World Endometriosis Society. All of these guidelines suggest that early intervention is key if we're going to make a difference to these young people presenting with symptoms very early.
Tất cả các cái nghiên cứu
Even in the National Action Plan for Endometriosis, they refer to the expansion of the ME program there and say that this is the best way that we can reach our young people through education. The ME program is endorsed by the World Endometriosis Society. So having a look now at the menstrual health and endometriosis, or ME program in schools, it's published in the ANSDOG Journal. And I want to draw your attention to 4 of the regions that the ME program has been presented in New Zealand. I just want us to concentrate on this category down here, where you can see the number of young women off school every or most months with dysmenorrhea. It ranges from 27%, 25%, 25%, 37% in one area, missing school every or most months. The average was 27%. So what happened in 2020 and 2021? Well, the average for these years was 31% of young people missing school every or most month. The cohort was 485, and that we didn't go to so many schools, of course, because of COVID and the restrictions placed on us. This is a graph of my patients, a longitudinal study from 2001 to 2015. This is just a bunch of earthquakes that I lost data and lost track of the study. But if we have a look at this bar here, we can see this is our under 20s. In 2001, only 12% of the patients who I saw were under 20. If we have a look here at the end of 2015, we can see that almost 60% were under 20, diagnosed and managed with endometriosis. And when we look further at this, these statistics, on this peak here, we can see that 96% went on for laparoscopic review, and of them, 98% were diagnosed with endo, and half had stage 1 disease. Now, this is not an indication to say we must laparoscope all our young people with dysmenorrhea. Definitely not. What it is saying is that if you are suspicious that she may have endometriosis, the chances are that it will be found and you can intervene early, maybe with a medical management plan or whatever it is that you're going to help her with her symptoms and her pain. It will be of no surprise to you that her presenting symptoms were dysmenorrhea, lower back pain, bowel symptoms, bloating and fatigue. And I can tell you that at the end of 2019, about 62% of the patients I saw were under 20. And when I asked them why they are presenting there, how come, they often say to me, we heard the ME program at school. So here's a question for you again. This is Laura with very, very mild stage endometriosis, and Lisa, who's 32, with advanced stage 4 endometriosis. We don't have time to debate it, but who had the worst pain? Well, of course, the answer is we don't know. We can't see pain. But my question again is, can we stop this from becoming this? And we think by intervening early and managing well, we have a very good opportunity to stop the progression of disease to that level. So let's commit to stopping the harm and significant human and societal impact of dysmenorrhea and endometriosis. Let's look at professional adolescent education as an appropriate screening tool for early intervention for endometriosis. And of course, we can collaborate. I'm working at the moment with Otago University to develop the program as an online program that should be available to the world if I manage to pull this off, and I'm very confident that I will. At the moment, it's undergoing a lot of scrutiny, so we are working on it. It does have global relevance and implementation. So back to our questions. Will we find pathology in those with dysmenorrhea? Sometimes we do. And please don't ignore a negative laparoscopy because it may well be that on that day it was not seen. And it may have been too mild to actually be seen, but in the hands of an experienced gynecologist with advanced laparoscopic skills, we often do find pathology in very young women. Should we investigate further? We absolutely should. So if all your findings are negative, please continue to ask the questions and do what we can to help this very young and vulnerable group. Should we be concerned? Indeed, we should. With well over a quarter of our young people missing school every almost months, we need to be very concerned and we need to intervene. I'm going to finish this talk with acknowledgement and special thanks to all the school students and teachers who have supported the ME program for 22 years. To my very esteemed study team, Professor Neil Johnson, Ms. Emily Brick and Mr. Michael Lee, and to ACE for including this presentation in the ACE 2021 program. And let's not forget what the World Health Organization is saying about endometriosis. Let's make sure every person with endometriosis gets the care they need to manage their symptoms. It's a matter of health, well-being, and human rights. And how are we going to take this further? By being at the World Congress on Endometriosis 2023 in Edinburgh, where hopefully we'll be able to meet together, have this debate, collaborate, communicate, and have a wonderful Congress. I really sincerely hope to see you there. Thank you so much.
Và cảm ơn các bạn đã chú ý lắng nghe.
Thank you very much, Professor Deborah Bush, for your excellent presentation. And the next speaker, we are very glad to introduce Professor Sun Wei-Wo. Professor Sun Wei-Wo was the past president of Asian Society of Endometriosis and Adenomyosis. Currently, he is a member of the board of trustees of the World Endometriosis Society, and he is also associate editor for Human Reproduction Update. Professor Sun Wei-Wo will give a talk on recurrence of endometriosis, how to win at Russian roulette. Please, Professor Sun Wei-Wo.
Hello, I'm Sun Wei-Wo. I'm from Shanghai OBGYN Hospital, Fudan University.
Xin chào tất cả các bạn, tôi tên là Sun Wei-Wo, đến từ Bệnh viện Sản Phụ Khoa Thượng Hải. Và tôi rất vinh dự và tôi muốn dành lời cảm ơn đến Hội Phụ sản Việt Nam. Hy vọng trong tương lai sẽ có nhiều sự hợp tác hơn nữa giữa Hiệp hội Lạc nội mạc tử cung châu Á và Hội Phụ sản Việt Nam. Và hôm nay tôi sẽ trình bày về sự tái phát của lạc nội mạc tử cung. Như các bạn đã biết, mục tiêu điều trị của lạc nội mạc tử cung bao gồm giảm đau, tăng tỷ lệ có thai cho những phụ nữ mong muốn có thai, và cuối cùng là trì hoãn tái phát càng lâu càng tốt.
In fact, the 7-year recurrence risk is much higher than playing Russian roulette. And because of the recurrence, we have reoperation that should increase the healthcare cost, and also increase the risk of adhesion, premature ovarian failure, and organ injury. So recurrence is actually just like a sword of Damocles. Actually always hanging on the head of the patient. Now, in summary, I think that the median 2-year recurrence rate is about almost 20%. 5 years range from 40% to 50%. So as a rule of thumb, is the recurrence rate increases 10% by each year after surgery. So the question is how we can win the Russian roulette. Now, after I think they wrote a paper that in 2009, I think that I realized there's a dramatic change in the landscape in managing endometriosis. For example, DenoJazz can substantially reduce recurrence rate, and essentially, if you keep using the drug, the recurrence rate is about 2%. However, there's some other issues. Cost, especially for low resources countries, and I think that not mentioning Vietnam, I think in western part of the China, where it's actually the resources low, and the monthly cost for DenoJazz, I think it's just too high. And there's also side effects and bleedings and amenorrhea, and also it does not reduce the lesion volume in deep endometriosis. So, and also, of course, you can always talk about risk factors, but when you look at literature, there's always conflicting, and also they provide little information on lesional histology, which could be more prognostic and more informative. And they may not be particularly specific for a given patient because they are true on the population level. Nor do they offer any countermeasure for any possible intervention. Of course, we can also talk about biomarkers. We actually were the first to publish papers on biomarkers. But on the other hand, these biomarkers, they give no clue on the completeness or thoroughness of a surgical removal of endometriotic lesions, nor do they offer any countermeasures for possible intervention. And essentially, as of now, there's a lopsided interest in the post-operation medication. And there are few randomized clinical trials, and these trials essentially span very short time interval. So, typically about 2 years, because if you expand beyond 2 years, the logistic and cost and resources is going to be huge. And it looks like that the DenoJazz appears to be very effective in suppressing the recurrence, and GnRH agonist does not seem to be very effective. So in this sense, more clinical trials are needed. And when we talk about the prevention of recurrence, we need to understand the causes for recurrence. So does the new lesion arise from minimal residual lesions, or that is in situ growth? Or does it arise from a completely normal location? So that's the de novo growth. And we try to answer this question from an angle of essentially a recurrence pattern. And unfortunately, so far there's only one paper that's actually from our lab and looked at the patterns of recurrence. And essentially, we can see that in the first 30 months after surgery, there's essentially the risk of recurrence is actually flat, constant. That means in reliability or survival analysis, we call it memoryless period. In a sense, it doesn't matter that actually, if you look at the patient has already survived or 10 months or 20 months, it doesn't matter. So there's no memory. Everything starts anew, fresh. And then after 30 months after surgery, and there's a huge jump. This actually means that the de novo foci may be less likely for those recurrence occurred in the first 30 months after surgery. So receding, reimplantation or regrowth of topic endometrium, the emergence of symptoms will take much longer, usually longer than 30 months. And the recurrent lesions could arise from minimal residual lesions that is undetected and thus unremoved in the primary surgery, or could be the result of spillage and dissemination of ectopic endometrial cells during surgery. So in this case, I think that there is a lot of evidence for the minimal residual lesions For example, the recurrence risk actually depends on the skill level of the surgeons. And we also come to understand that the surgery is actually a double-edged sword, because surgery can inflict trauma to the body. Surgery can accelerate lesional development through the activation of adrenergic signaling, adrenergic receptor beta 2 in lesions. There's actually, we have 2 papers that actually report it. And essentially, that the trauma due to surgery will activate the HPA axis and causing the release of adrenaline and also noradrenalines that will actually activate the beta 2 receptor on lesions. And so we also found that the surgical history is actually a risk factor with odds ratio of 3.6. So one time window that so far has been completely overlooked is the perioperative period. I think there's a critical time window for mitigating risk of recurrence, because surgical stress can induce the release of PGE2 and also adrenaline and noradrenalines. And pain, anxiety, fear, worries about financials and relational, and even whether there will be any person to take care of the kids. And these aggravate can activate the HPA axis and causing the release of adrenaline, noradrenaline, and also prostaglandin E2. And these compounds actually can suppress cell-immediate immunity. That's actually well documented. So essentially, there's a spillage and dissemination, minimal residual lesions that's actually been removed, and also tissue trauma, suppressed cell-immediate immunity, which actually causes the recurrence, making either the residual or the reimplanted small lesions to grow very quickly and lead to the occurrence of symptoms. Essentially, the current modality to control recurrence is the post-operative intervention, using either oral contraceptive or denogest or whatever. But in this case, they only make the lesions somewhat dormant. But occasionally, because of the pain, the lesion can still grow. So we probably should think out of the box and shift our focus to the perioperative intervention. Now, to answer this question, we need to, we cannot do it on humans. We have to resort to animal studies. Now, for this one, we actually did some studies, and we essentially try to mimic the incomplete excision, and when we induce lesions, and then when the lesions are well established, we removed about 90% of the visible lesions and leaving intentionally 10% of them. So, and then let it grow for 2 or 3 months, weeks, actually in this case 2 weeks, and then we did the second surgery. Now in this case, we actually used angiographolite, which is actually N-kappa B inhibitor and beta blocker, and also a combination of beta blocker and also angiographolite. And we can see that when you do the perioperative intervention, then 2 weeks after, that the lesion weight will all significantly reduced as compared with the untreated group. As a result, you can see the pain behavior also improved, and also we can look at some of the molecular processes involved in lesional progression. Now these PRB and these are phosphorylated P65s and N-kappa B, which we know that it's actually the biomarkers for recurrence. We can see that all these intervention cause the upregulation of PRB, but also suppression of NF-kappa B. And also some of the molecular processes involved in lesion progression, for example, the Yutaka hearing, the expression are increased, suggesting that the epithelial mesenchymal transition seemed to be inhibited. So, and of course, this is a minimal residual lesion model, and we also developed a recurrence model. We call it the spillage and dissemination models. Essentially, we established lesions in mice, and then 4 weeks after, we removed all lesions, and then, but we also kind of injected part of it actually back into the peritoneum cavity, and 3 weeks after, we looked at the lesions again, and it looks like that this model is actually very successful. You can see that the SMD group actually had higher lesion weight, and also we looked at the no intervention, and we also, besides beta blocker and anticoagulate, we also looked at the ketorolac, which is actually a painkiller, and it's very common to have a very high safety profile, and also NF-kappa B receptor inhibitor, repeated. And this is the second surgery, and we can see that all these interventions resulted in significantly reduced lesion weight. The pain behavior actually seemed to be improved, unlike the no treatment group, which actually deteriorated further. And for all these markers, that PRD and also epithelial mesenchymal transition, they all seem to be improved. And of course, that for the residual lesion models, we can see that this is also true for ketorolac and also beta blocker plus anticoagulate and perpetin. All 3 types of intervention, they significantly reduce lesion weight. Now, keep in mind that the ketorolac is only administered before the surgery, once. So you can see there's a pre-operative intervention that actually resulted in very good reduction in recurrence. So in this case, you can see that all these markers seem to suggest that yes, indeed, they seem to work. So in the future, I think that one possible intervention is the perioperative or even perioperative intervention by ketorolac. So in this case, that will reduce, essentially remove all these lesions by boosting cell-mediated immunity. So in a word, a perioperative period is a critical window, and compared with a long post-op period, perioperative period is very short. Beta blockers are generally safe, inexpensive, so are COX-2 and NF-kappa B inhibitors, and also the neurokinin receptor 1 inhibitor, perpetin, is also very safe. And if it works, that of course will be tested on humans through clinical studies. I think there should be, if proven to be work, I think that it should be much more economical than post-op intervention. And also it would elicit better patient compliance. And so 2 years ago, actually, Dan Martin and I actually wrote an opinion paper, essentially that try to call surgeons' attention to this critical time window. So in conclusion, reducing recurrence risk is an unmet medical need. Nearly all efforts have been focused lopsided on post-op intervention. Perioperative period is a critical yet neglected time window that deserves more attention and a possible way to win the Russian roulette. So if it works, it should be more economical and has less side effects. So I would call upon you, Vietnamese OB/GYN doctors, and maybe you can actually do some pilot studies or even clinical trials and to see if it works. And of course, we still need to do some mechanistic work. So with this, I'll thank my collaborators, and I'll be happy to entertain any questions. Thank you.
GI, HIEI, and the World Endometriosis Society. Professor is to President of the IFFS and Chair of Federation International Gynecology Obstetric Community on Reproductive and Development Environment and Health. Now, please, I would like to invite Professor Linda Gaidais. Please.
Hello, I'm Linda Giudice, and I am the president of the International Federation of Fertility
Xin chào,
Societies
tôi là Linda Giudice,
and
Chủ tịch của Hiệp hội Sinh sản Quốc tế,
the chair of the
và đồng
FIGO
thời cũng là thành viên của Hội đồng FIGO.
Climate Change and Toxic Environmental Exposures, and I am delighted today to be with you to talk about the environment and endometriosis risk. I have no disclosures. Today, we will begin just touching briefly on inflammation and endometriosis, and then risks of developing disease, evidence that endocrine disrupting chemicals, or EDCs, may relate to endometriosis risk, and some approaches to minimize exposures. So I think we all know that endometriosis is an estrogen-dependent common disease where endometrial-like tissue exists outside of the uterus and elicits inflammation and scarring. Central to the pathophysiology are inflammation, disrupted progesterone signaling, and remember that progesterone is an anti-inflammatory and it also counteracts effects of estrogens. And there's also enhanced estrogen or pro-inflammatory signaling associated with the disease. These processes are interrelated and largely contribute to the pain and infertility in affected women. And many of these processes are believed to be mediated through epigenetic mechanisms affecting many of the steroid hormone receptors, and also inflammation and reactive oxygen species, elevated cytokines, and altered steroid hormone receptors and their coactivators. So what is the risk associated with endometriosis, and how does this relate to inflammation and the disease? Stacy Mismer showed years ago that increased exposures to estrogen, such as early menarche, nulliparity, and now more recently over time, we have learned in utero as well as postnatal and adult endocrine disrupting chemical exposures are associated with increased risk, as we'll see shortly. In addition, low birth weight, congenital anomalies, family history, and there are some data that show differences across races and ethnicity. Decreased exposures are associated with lower estradiol exposure levels in time, including lactation for more than 3 years, more than 3 children, and also smoking. And risk is thought to be about 50% genetic and 50% environmental. And of course, there are likely gene-environment interactions, but today we are going to focus on environmental. And in particular, I'd like to focus on endocrine disrupting chemicals. So these are chemicals or mixtures that interfere with any aspect of hormone action at any time of development and or during the life course. And of course, development of the uterus is an estrogen-dependent process in utero, and we know that endometriosis is an estrogen-dependent process, and many of these chemicals have estrogen-like actions. These include some chemicals that are EDCs, include persistent chemicals like PCBs, dioxin, tributyl-tin, and non-persistent chemicals like plasticizers in children's toys or personal care products that are not persistent but are measurable in people and in animals due to their either chronic use or chronic exposure. So there are many, many opportunities for being exposed to endocrine disruptors, and nearly every person has measurable contaminants in their bodies. This was a representative cohort study of a select population in the US demonstrating that, and that mixtures are the rule. And it's also been said that babies are born pre-polluted. Not very good news. And exposures occur by ingestion, inhalation, transdermally, and transplacentally. And there are times of exposures that are more vulnerable to disruption by EDCs than other times. And if you look at developmental exposures at the blastocyst stage, in utero, immediately postnatally, and in childhood and adolescence, these are mainly periods of rapid cellular proliferation and differentiation, but also adult exposures can result in diseases brought about by endocrine disrupting chemicals. So how do we know that these chemicals may affect health and reproductive health? Data from animal and in vitro models provide mechanistic underpinnings involving hormone signaling and its disruption, epigenetic events, and inflammation. Observational cohort and epidemiologic studies reveal data correlating environmental exposures and human health outcomes. We can't do experiments, obviously, in people. That would be unethical. So epidemiologic data are what we rely upon with mechanistic underpinnings derived from animal and in vitro studies. Also, wildlife observations can give insights, and importantly, systematic reviews and meta-analyses evaluate the data and put it all together. So, and this then provides us with scientific evidence. So let's look at some examples of developmental endocrine disrupting chemical exposure and endometriosis. There is evidence in an abundant literature of rodent studies that demonstrate developmental exposures result in endometriosis-like tissue within the offspring. So if, and many of these chemicals have demonstrated this, shown here, so if the dam, the mother, is exposed, and then the fetus, and then subsequent neonate and adult, the F1 generation, that there is endometriosis-like tissue that occurs both in the fat tissue and also in the female reproductive organs. And in humans, we know that there are several reports of endometriosis that is found in human fetuses, and also an early study that showed in utero exposures are associated with increased risk of endometriosis, mainly with regard to diethylstilbestrol, which is a synthetic estrogen, similarly to what was found in animal models. And this is the study from Stacy Mismer and colleagues of in utero exposure to DES increases a woman's risk of endometriosis as an adult. So this was a Nurses Health Study 2 prospective cohort study, large population base. And what they found was that exposure to DES resulted in an 80% increased risk of endometriosis, as shown here. They also identified other risk factors in this population. So let's take a look now at adult exposures and endometriosis. And what are the groups to look at? Well, again, experimental models. And these, as you'll see, briefly show that EDCs can promote endometriosis and result in the abnormal progesterone signaling that is observed clinically in women. In addition, human epidemiologic studies are important. So the very first study in an animal that demonstrated adult exposure to dioxin, an endocrine disruptor, and resulting in endometriosis was a study done on non-human primates, the rhesus monkey, that were treated with dioxin for 4 years. And then 10 years after the treatment, these animals began to show signs of pain and gastrointestinal obstruction, and they were diagnosed surgically with endometriosis. And the incidence of disease was directly correlated with the exposure, and the severity of disease was dose-dependent. And of course, there's a baseline incidence of endometriosis in a captive population, but the incidence among animals was much higher than those of controls. Of course, these are a very limited number of animals, which is challenging, of course, to do with the non-human primate species. So there are a number of other approaches that have been taken, looking at the endometriosis phenotype in adult female animals treated with endocrine disruptors. So we just talked about the rhesus monkey, but also treatment in adult animals, such as the skid mouse, with dioxin promotes an endometriosis-like phenotype, disease that so this is surgically induced disease, and you can see this is a control, and this is an animal treated with TCDD, and you see endometriosis-like tissue, and importantly, with a loss of progesterone receptor and TGF-beta-2, very similar to what is seen in human endometrium, and also the ratio of PRA and PRD. In addition, dioxin and other halogenated hydrocarbons promote endometriosis in mouse models, not just the skid mouse. And non-persistent EDCs like BPA and BPF, as well as this phthalate congener DHEP, promote endometriosis in mouse models. Human epidemiologic studies have been also revealing, and they have their own set of challenges. So there are correlations of persistent and non-persistent EDCs and endometriosis risk. This is a narrative review from Germaine Buck-Lewis a few years ago that showed that dioxin and dioxin-like compounds had significant odds of endometriosis diagnosis, and organochlorine pesticides, and especially the beta-hexachlorocyclohexane, had a 72% higher odds of endometriosis diagnosis per 1 standard deviation increase. They found that PBDEs were not significantly associated, and there were equivocal associations between PCBs and the perfluorinated compounds, which are all persistent. On the non-persistent side, benzophenone type UV filters had a modestly increased risk of endometrial diagnosis, and also they found no reported significant associations of surgically visualized or MRI diagnosed disease with bisphenol A, and they found equivocal evidence with phthalates. Now, subsequently, more recently, this group includes many of the authors on the previous slide and additional ones, and they conducted a meta-analysis looking at the correlations between exposures to dioxins and endometriosis. So this slide shows the forest plot for the dioxins, showing an increased risk of odds ratio of 1.65, with the 95% confidence interval here. And this is for PCBs, showing something very similar here. These are the odds ratios. And then finally, with regard to organochlorine pesticides, again, an increased odds ratio of almost 2, with confidence intervals, again, not crossing 1. And then most recently, this is another meta-analysis of epidemiologic studies, and this one looked at 30 epidemiologic studies. And they found no significant associations with BPA, similar to the previous study that we just reviewed. PCBs, there was an elevated odds ratio. Also organochlorine pesticides, again, concordant with the previous results. Phthalate esters, and in particular DEHP. And overall, the odds ratio across all exposures and endometriosis that were in the literature that they reviewed demonstrated an elevated odds ratio with a confidence interval shown here. So the current meta-analysis strengthens the evidence that specific EDCs or their metabolites may promote the occurrence of endometriosis. There are many challenges with regard to epidemiologic data, and I think you can see these. The accuracy of the disease diagnosis. Right now, in the absence of a biomarker, one has to rely on surgical diagnosis, which is, of course, reliable, but also can be, one can diagnose with ultrasound or MRI. However, the disease is highly heterogeneous. And so when we say a population that has endometriosis, what is really the population we're looking at? Those with endometriomas, those with deep infiltrating disease, those with a combination of the two, or in addition, superficial peritoneal disease, those with extrapelvic disease. So there's still a lot of work to be done there. Also, timing of exposures relative to diagnosis is very difficult to determine. And the choice of the study population is also challenging because the disease is common. What we know of those who are diagnosed with endometriosis, it's usually because they have symptoms, but there are also women who do not have symptoms who have disease. And some studies use case control and others use cohort study designs. And who is the control group? Exposures to mixtures are the rule. And so if one's looking at one chemical, how does that really reflect more than one chemical, which is the norm? And then quantifying chemicals, especially lipophilic ones, which are not usually abundant in the blood, but more in the fat tissue, this can be challenging to quantify in humans. And there can also be confounders in terms of history and life experience, BMI, parity, breastfeeding, cigarette smoking, alcohol use, and birth control pills or other hormonal and other treatments for disease and pain or infertility. And then outcomes ascertainment. Most of these studies do not look at correlation of extent of or amounts of EDCs determined and extent of pain and also infertility. So differences in study design and population and disease heterogeneity, laboratory and analytical methodologies may explain some of the equivocal findings on EDCs and their relationships to endometriosis risk and symptomatology. So before leaving you, I would like to give at least some brighter side, and that is our committee in FIGO has put together some infographics with regard to, for patients as well as healthcare providers, avoiding toxic chemicals before, during, and after pregnancy. And this, of course, applies also to women who have endometriosis or who may have a family history of endometriosis. So avoid eating, drinking, or storing food in plastic and not microwaving in plastic, cooking with cast iron or stainless steel, not nonstick pans that have chemicals in them. Avoid eating fish high in mercury or PCBs. Eat fresh organic foods if possible and clean off pesticides. Limit cosmetics or at least find information about personal care products. Avoid dry cleaning or stain treating clothing. using a wet mop when cleaning to get rid of dust, which harbors a lot of EDCs on the floor, and avoid consumer products with flame retardants, and the very simple thing of removing shoes before entering one's home. We are currently working on a version of this in Vietnamese also that we hope to have within the next year. So I would like to thank you for your attention. And as president of IFFS, I'd like to welcome you to the World Congress in Athens next year in Greece. So thank you.
Thank you very much for the presentation from Professor Linda Judith. And now I would like to introduce and invite Professor Lon Hammenholz to have the presentation about the global collaboration in endometriosis. Professor Lon Hammenholz is the Chief Executive of the World Endometriosis Society, Executive Director of the World Endometriosis Research Foundation, and also the publisher of endometriosis.org. Professor Hammenholz, please.
Me to present at this prestigious meeting about the global collaboration in endometriosis, and in particular the work of the World Endometriosis Society and the World Endometriosis Research Foundation.
Xin cảm ơn lời mời của ban tổ chức và tôi rất vui được tham dự để trình bày về cái vấn đề hợp tác quốc tế.
We heard very accurately earlier on from Deborah Bush the need for an accurate diagnosis of those that present with symptoms of endometriosis. And the overall goals in our field is to achieve that, to develop targeted treatments, and ultimately, of course, to prevent the disease in future generations. To achieve that, there is this huge puzzle that needs to come together, in which we need to understand disease mechanisms, as we've just heard from Professor Judith. Why do lesions develop? Why do they cause symptoms? And how do they respond to treatment? And we know that there are centers around the world that are addressing these questions. Some are collaborating together, and everybody is contributing to this puzzle. But to do so in a meaningful way, we do need standardized data and specimen collection, we need validated laboratory models, and we need robust study and trial designs. And it is because of these needs that the World Endometriosis Research Foundation's Endometriosis Phenome and Biobanking Harmonization Project came about. Basically, to develop a collection of detailed phenotypic clinical and surgical data in endometriosis, and to develop standardized operating procedures for fluid and tissue sample collection. To do so, we can reduce data variability and also facilitate comparability of the data that is collected around the world, and through that encourage and enable large-scale collaborative studies in endometriosis. So we standardized data and biospecimen collection, how to collect surgical data, papers that were published back in 2014 and which are available from the Worth Effect website, clinical data, fluids, as well as tissue in endometriosis. Earlier this year at the World Congress on Endometriosis, Professor Stacy Misma presented that we now have the largest collaborative repository of clinical forms in endometriosis, more than 25,000, more than 4,500 surgical forms, more than 6,000 blood samples, more than 3,000 urine and saliva samples, as well as peritoneal fluid samples, more than 2,000 endometriosis nodules and lesions, as well as endometrial biopsies, all collected using the same data, so that these can be compared amongst the centers that are using these tools. And right now there are 51 centers in 22 countries using the Worth Effect data and biospecimen collection tool. They have also been translated into 16 languages, with another 2 languages are currently being processed and finalized.
Trên 22 quốc gia, và do đó là cái quỹ nghiên cứu của chúng tôi có một cái dữ liệu khá đa dạng.
So this global collaboration sees the early days of a paradigm shift in how we do scientific discovery in endometriosis, because we now have valid, diverse, inclusive, and deeply phenotyped data, as well as careful and thoughtful study design and analysis. And there are a number of projects that have come out of this initiative, including a European Union funded project involving 40 partners in 14 countries, looking at translational research in pelvic pain, with endometriosis as one of the specific examples. And this is being led by Katie Vincent and Jens Nagel. A sub-partner of that is EndoDiag. This is a for-profit company that collects biospecimens and endometriosis, and have chosen to use the Worth Effect tools so that all the data and biospecimens they collect adhere to these, international standards. Another example is a project headed up by Idalis Flores from Puerto Rico. She translated the tools into Hispanic and has basically done the first Hispanic Latino study in endometriosis across 11 countries in the geographic, the Middle and Western Southern American geographic area. Excuse me, I apologize. I have a bit of a cold, I apologize. Another study is the WISE study. What is endometriosis? This is led by Asli Abbas and Stacey Misma, and comprises data that has been collected from 3 large studies from the Universities of Oxford, University of Harvard, and Michigan State University as well. And this is bringing together participant data and samples to try and develop patient characteristics in order that we might be able to share experiences of those with endometriosis and not least the outcomes. COHEA is the Cyprus Women's Health Research Initiative led by Nilüfer Ramioglu. This is the largest study that's ever been done in the Mediterranean area of Europe, comprising more than 8,000 women with endometriosis, again collected adhering to the Worth Effect standards. The endometriosis clinical and genetic research in India is headed up by Rahul Gabiji, comprising the entire continent of India, and he has been instrumental in getting the tools translated into 5 regional languages so that all women have an opportunity to be able to share their journey with endometriosis. Mira Musa from Oxford University has initiated a study across the entire Middle East. 23 countries is involved, that's 7% of the world's population, looking at the experience of women in that region with pelvic pain and endometriosis. This will form the basis of her PhD, and her results are very, very exciting to read. And finally, this is the most recent initiative, again, funded by the European Union. This is a collaborative amongst 14 partners in Europe, looking at collecting phenotypic data in endometriosis, both genetic and the experience of those with endometriosis, with an ultimate goal to utilize machine learning to see whether this can improve the diagnosis of endometriosis. Again, going back to what Deborah Bush emphasized in her earlier presentation, so that we can improve not just diagnosis, but hopefully also management and outcomes of the disease. Ongoing research initiatives, I mentioned earlier, robust models in endometriosis. The World Endometriosis Research Foundation is looking at the moment at developing standards for how to use experimental models. This is being led by Kalon Brunner-Tran and Erin Greaves. We are looking at standardizing how to do clinical examination in endometriosis, hopefully also contributing to the earlier and better diagnosis of the disease, in particular in the younger population, led by Paul Young from the University of British Columbia. And finally, looking at how to utilize diagnostic imaging in endometriosis, led by George Condis and Matthew Leonardi. Moving on to the World Endometriosis Society. Its mission is to advance evidence-based standards and innovations for education, advocacy, clinical care, and the research in endometriosis and adenomyosis. We do so in collaboration with our stakeholders and global partners for the very focused purpose to improve the lives of those that are affected by endometriosis and adenomyosis, as well as their families. Let us never lose sight of that in all that we do. So what does WES do? Well, this year we executed the 14th World Congress on Endometriosis, a virtual meeting that took place in March, and we teamed up with Frontiers in Research to develop specific research topics for publications from that meeting in the Frontiers publication group. We're now, of course, gearing up for the 15th World Congress in Edinburgh in May in 2023. More about that in a little bit. WES also publishes consensuses on the management of the disease, on the classification of the disease, and have, amongst others, collaborated with ESGE ESHRA to develop consensus on how to tackle endometriosis surgically, in particularly when it comes to cysts and deep endometriosis. More recently, where the AAGL and the ASRM were added to this collaboration, looking at developing a standardized glossary in endometriosis with a long-term view to see whether it is possible to improve classification of endometriosis. But naturally, this is going to take a massive amount of data to be collected in order to achieve this goal. We're also involved in the core outcome research looking at adenomyosis to see if a standard core outcome set can be developed for research in this sister disease to endometriosis, if you like, but certainly something that needs to be addressed. The World Endometriosis Society started a little over a year ago to have regular grand rounds on specific topics in endometriosis. These are now available on our website, and there will be a specific lounge developed for members of the World Endometriosis Society to also benefit from all the presentations from the Congress earlier this year. WES has also launched a mentoring program and currently have matched 33 mentees with mentors, so early career scientists or clinicians team up with more experienced scientists and clinicians to guide them through the perils of developing a career in endometriosis. This is hugely successful, and we will be launching another call to be part of this program in January or February this year. Finally, we also do brain gymnastics, groups that meet to try and shape endometriosis. What are the clinical challenges and what are the scientific challenges that need to be addressed, and present such things to the World Health Organization, which earlier this year launched their first fact sheet on endometriosis, to which, of course, the World Endometriosis Society provided input and collaboration. So how can you make a difference? Well, you could become a member of this global community. I've already read out the mission, but I would like to remind everybody that in everything we do, we have strength in numbers. The more of us that work together, the stronger is our advocacy, and the more the importance of endometriosis will be highlighted. We will therefore, through that strong advocacy, be able to influence policy, and hopefully through continued global consensus improve treatment standards and ultimately set research priorities and obtain more grants for the important work that we all do and that all goes hand in hand. And more of this will be revealed as we progress towards the 15th World Congress on Endometriosis. Abstract submission will open in September 2022. That's not very far away. So start thinking about right now what you want to present in Edinburgh in May 2023. Get your research moving and get your abstracts in, and I hope to welcome you to the United Kingdom then, and thank you very much for your attention.
Abstract sẽ được bắt đầu vào từ tháng 9 năm 2022. Chúng tôi xin chân thành cảm ơn sự lắng nghe của các bạn.
Thank you very much for a comprehensive review about the activities of World Endometriosis Society, and your information are very important to our colleagues working in the fields as well as having interest in endometriosis in general. So with the presentation from Professor Hammenhorst, we are already finalizing the presentation schedule for this session, and we would like to start the discussion part of this session. There are several questions for our speaker. We would like to start with a question to Professor Khaled Khan. We have a question from our audience. Does adolescent endometriosis have a poorer prognosis comparing to adult endometriosis? And what is the management means treatment and follow-up in the adolescent patients? Professor Khaled Khan, please.
Okay, thank you for your very nice questions. I would appreciate that. So your first question is, what is the difference in the prognosis of adolescent endometriosis and the adult endometriosis? I think we need a longitudinal age-dependent study to answer these questions. So in my lecture, I mentioned that most of the endometriotic lesions in adolescent women are the hemorrhagic lesions, active red lesions. And these groups of young women, they mostly manifest the symptoms, pain symptoms from moderate to severe pain symptoms. So the important thing is that these groups of women, they don't want to visit OBGYN doctor. They go to the drugstore, they control by themselves, or they take the non-prescribed medicine. So for that reason, as I mentioned, that we already established endometriosis awareness promotion project, and our target and our aim of this project is to motivate and to pick up, identify the high-risk groups who are supposed to develop endometriosis, and motivate these high-risk groups of women to come to the OBGYN department to take an exam for the early diagnosis and management of endometriosis. And if we find that these high risk groups after performing the ultrasonography, because most of these women are reluctant to take a laparoscopic surgery. And if we can diagnose early endometriotic lesions, and then I think we can prescribe the NSAID. They already took NSAID, but we can prescribe OC or the progestin compounds. The purpose is to prevent the cascade in the progression to advanced endometriosis. That is our main purpose. And in case of adult endometriosis, as I shows that, most of the lesions are fibrotic lesions. And because all these hemorrhagic lesions are covered by the fibrotic tissue, and they suffer from the different adhesive manifestations. So in addition to the pain manifestation, these groups of women suffer from a state of subfertility or infertility. So we recommend these groups of women to take the laparoscopic surgery to effectively remove all the adhesive lesions together with the endometriotic lesions. And then we should advise them to try for the natural pregnancy. And yes, in case of the adolescent groups of women, after treating with hormonal treatment, OC or progestation compound, if we need to follow up these cases. And if these young groups of women still become resistant to treatment, or they don't have any symptom of the recovery of the symptoms, then we should explain the consequence of endometriosis to these young women, and we can motivate them to take an laparoscopic surgery for the early removal of the lesions. And I think that is the best approach for these groups of women. So I think this is my answer. So in my last slide, I'm very sorry that I missed to mention another university in Vietnam, that is the obstetrics and gynecological department, very big hospital under the affiliation of the Hanoi University. The Dr. Ha and her team are so kind, and they performed this questionnaire survey with a huge number of medical and nursing students. So I'm really thanks to Dr. Ha and her very active team. Thank you.
Thank you very much.
Yes, thank you. And the next question from audience to Professor Sun Wei-Wo. Do you hear me, Professor Sun Wei-Wo?
Yes, I can hear you. Yes. Hi.
Yes. The question concerning the prevention of recurrent. Your presentation with huge data on animal experimental studies. And the question concerning the treatment in human with operation for endometriosis. And specifically, what medication do you recommend for prevention of recurrent, and the protocol?
Well, actually, there are several of them. One is the beta blocker, which is a very cheap and pretty safe, except some contraindicative patients, and also anticoagulant, which is actually anti-inflammation and also anti-COX inhibitors. So these are very cheap and very inexpensive and pretty safe. The other one is the neurokinin receptor 1. There's actually a commercial drug called epinephrine. This is actually used for treating chemotherapy associated vomiting nausea, that sort of things. The other one is ketorolac, which is actually a commonly used, it's an old drug. It's used for pain, treating painkiller. And they are pretty safe, very cheap, and we can use it before the operation, just once, because this essentially can boost cell-mediated immunity, and they actually can remove the residual lesions, as well as the endometriotic cells spilled and also disseminated into the new locations.
Thank you very much. We have another question from the audience to Professor Deborah Bush about the young unmarried women having clinical symptoms of endometriosis, but reluctant to the diagnosis and also to management, reluctant by themselves or reluctant by their parent, because it is related to a very young women, adolescent women. Do you have any experiences can share with us about dealing with this very specific group of subjects?
Thank you very much for the question. I think I understand it. I think probably what we're referring to here are different cultural experiences from different countries. So I would think that maybe your experiences in Vietnam, for instance, might be different from ours in New Zealand, where we in schools with the ME program for 22 years, we've been talking very openly. One of the things that I was very interested in, Professor Khan's response to this is looking at diagnosis, looking at coming in for an examination, whereas our new clinical pathway for the treatment of endometriosis and the management in New Zealand is not specifically to do examination in these very young women, rather to take very good history taking, listen very carefully to the symptoms, and maybe we can manage their symptoms and their pain without actually examining them or an internal scan. So I think that maybe there are some cultural things here that may be different in your country and than what we are doing. And I think that one of the things that we are really quite probably extending ourselves is managing on a suspicion of endometriosis rather than the actual diagnosis, because one of the things that we're finding is trying to reduce suboptimal multiple surgeries. We're seeing and diagnostic only procedures. We're trying to avoid these so that we're having the first surgery being the best surgery where the disease is excised, and that may happen down the track rather than a diagnostic procedure up front or a procedure that is not generally performed by a gynecologist with advanced laparoscopic skills. So I think it's complex. There are many things for us to consider, but managing this age group is very, very special. And we have to do that with care, with sensitivity to their age, and with sensitivity to their culture and respect of their family wishes too. And I think that might be one of the things that hold them back from going and seeking help, because they're frightened about what might happen to them. And I think that's also a concern for parents who might be thinking that their young daughters are going to be examined. So it is something for us to consider very carefully in our own setting, and I encourage you all to do that.
Thank you very much for your answer and your advice. I think you raised a very important issue, is the sensitiveness of our medical community to this very special group of subjects, not only medically sensitive, but also culturally sensitive. Thank you very much.
Yes.
Yeah. To Professor Lon Hummenhorst, we don't have the specific question, but I would like to mention that the interest among medical community, OBGYNs, colleagues, as well as as well as the interest of community, even in Vietnam and many other Asiatic countries, are increasing. So in the future, in very near future, our colleagues from Vietnam will, I do hope, and we will promote to play a more important role in the roadmap of Asian endometriosis society, as well as the World Endometriosis Society. So thank you very much. And we look forward to the next Congress of Asian as well as the World Endometriosis Society. On behalf of the organizing committee, the Vietnam Association of Gynecologists and Obstetricians, we would like to send the warmest thank you from Vietnam, from VAGO, the Vietnam Association of Gynecologists and Obstetricians, to all our distinguished speakers, our distinguished guests from Tokyo, from New Zealand, from US, from China, from many other countries. Thank you very much, and looking forward to have the opportunity to welcome all of you to our event in the future. Thank you very much, and goodbye.
Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye.
Tổng kết đi, tổng kết đi. Bật camera. Vâng, kính thưa quý vị đại biểu, kính thưa quý thầy cô, kính thưa quý đồng nghiệp. Như vậy, phiên 4B chiều hôm nay của chúng ta đã kết thúc sau 5 bài báo cáo. Trong đó thì chúng ta đã có cái bài báo cáo của giáo sư Khaled Khan đến từ Đại học Kyoto về vấn đề thực trạng, sự phát triển và các vấn đề về lạc nội mạc tử cung ở thanh thiếu niên. Đây là một cái lĩnh vực mà vẫn đang còn bỏ ngỏ và rất nhiều thách thức được sự quan tâm của rất nhiều quý đồng nghiệp. Nó thể hiện qua cái bài báo cáo của giáo sư Khaled Khan, cũng như là rất nhiều câu hỏi về cái lĩnh vực lạc nội mạc tử cung ở vị thành niên đã được gửi về, cũng như là một phần trả lời rất là ngắn gọn. Chúng tôi đã nhận được rất nhiều các cái câu hỏi liên quan đến lĩnh vực này, sẽ chuyển đến giáo sư Khaled Khan, và ban tổ chức hội nghị sẽ có dịp chia sẻ các cái phản hồi của giáo sư Khaled Khan đến quý đồng nghiệp. Giáo sư TS.BS đã có một cái bài trình bày về can thiệp sớm, thống kinh và tầm quan trọng, cũng là một cái chủ đề rất hot đối với cái đối tượng phụ nữ từ độ tuổi vị thành niên cho đến cái độ tuổi hoạt động sinh sản, mà trong đó thì lạc nội mạc tử cung vẫn là cái nguyên nhân hàng đầu. Chính vì vậy mà cái can thiệp sớm rất là quan trọng, và một số các cái chương trình giáo dục sức khỏe, ví dụ như là cái ví dụ minh họa của giáo sư TS.BS ở New Zealand cũng đã cho chúng ta thấy cái hiệu quả. Giáo sư Sun Guigo đến từ Trung Quốc đã chia sẻ cho chúng ta những cái thông tin, những cái kinh nghiệm về cái cách thức để chúng ta có thể xử lý cái lạc nội mạc tử cung tái phát. Các cái mô hình nghiên cứu động vật của giáo sư nêu ra cũng đã giúp cho chúng ta có được các cái quan điểm để có thể ứng dụng trong cái xử trí quanh phẫu thuật, chu phẫu cũng như là các cái hướng nghiên cứu mới về điều trị chu phẫu trong lạc nội mạc tử cung. Bài báo cáo thứ tư của giáo sư Linda Judith đã đề cập đến một cái lĩnh vực cũng rất là hot trong giai đoạn hiện nay, đó là môi trường và tác động của môi trường đến sức khỏe. Cụ thể là cái mối liên quan giữa môi trường và nguy cơ lạc nội mạc tử cung. Đã có các cái bằng chứng được nêu ra về mối liên quan giữa các cái chất gây rối loạn nội tiết với lạc nội mạc tử cung và những cái cách thức để mà chúng ta có thể hạn chế cái tình trạng phơi nhiễm này. Và cuối cùng là bài giới thiệu về cái khả năng và những cái định hướng hợp tác toàn cầu chuẩn hóa trong nghiên cứu, trong thực hành đối với bệnh lý lạc nội mạc tử cung của giáo sư Lon Hummenhorst, là giám đốc điều hành của Hiệp hội lạc nội mạc tử cung thế giới. Phiên báo cáo 4B của Hội nghị Phụ sản miền Trung, Tây Nguyên mở rộng lần thứ 9 đến đây là kết thúc. Chúng tôi xin trân trọng gửi lời cảm ơn đến quý vị trong chủ tịch đoàn. Đặc biệt xin trân trọng gửi lời cảm ơn đến 5 diễn giả quốc tế của phiên này, và xin trân trọng cảm ơn tất cả quý đồng nghiệp đã tham gia, đã chú ý lắng nghe, đã đóng góp câu hỏi và đóng góp cho cái sự thành công của phiên này cũng như là của Hội nghị Phụ sản miền Trung Tây Nguyên mở rộng lần thứ 9. Xin hẹn gặp lại quý đồng nghiệp, quý thầy cô trong những cái hội nghị, những cái sinh hoạt khoa học tiếp theo. Xin trân trọng kính chào.